Thank you for coming. I know everyone has busy schedules, and we very much appreciate your making the time to come and see us. Maggie and I have been presenting here for several years about skin cancer prevention and how important it is for nurses to be on the front line in trying to prevent skin cancer and teach patients. And my focus of recent times is to establish on the EMR in hospitals patient education using CDC guidelines to help prevent skin cancer. So we would very much like to see Winthrop, which is a magnet institution, be the first hospital on Long Island to have that established on their EMR, and nurses to be able to be on the front lines doing the education for the patients. And then that can improve your Press-Ganey scores and with patient education, and it would make a great deal of difference in the community. So my focus in my area of research is on skin cancer prevention. And back in the day when I was doing my doctoral dissertation, I was doing research, and I found Maggie and Jack Biggane on the computer, and I actually called them. And remember that? A long time ago. And we met for pizza at my favorite pizza place, and I think Jack especially liked me after that because he said I chose a good pizza place. And, and we've been working together ever since, doing presentations at hospitals and doing a nursing initiative and many other activities like that. And Maggie's going to now talk about some further initiatives with the Molloy Biggane Foundation that she's going to help establish or has established in teaching the community and public policy changes.
Thanks, Victoria. Thank you, Grace, and the nursing educators for bringing us here today. We feel like this is a wonderful forum to educate nurses who see their patients on a very regular basis about the dangers of skin cancer and, moreover, role modeling, good behavior, what these nurses, how they help their patients, what the patients can bring home to the families, help all of us in the community. So beyond that, I just want to touch on a few things that our foundation has been involved with in the past 16 years. I don't know if all of you know that we lost Molly when she was 20 from melanoma. It was a mole high on her thigh. She went to have a regular checkup at the pediatrician. She was a sophomore in college, and it was missed. So it went very fast. She entered Sloan in April, and in November she had passed. And at that time, she was on interferon, which was a very aggressive chemo drug, and thank God there are a lot more opportunities in terms of therapies, which you'll hear about later, that are out there today for patients. However, unfortunately, melanoma and skin cancer statistics are on the rise. And one of the big reasons for women, and I don't know if you caught that statistic outside, 25 to 30, it's the highest cancer, is because of tanning beds. Mm-hmm. So we did a very large social media campaign last year, and it went viral. And basically, it taught the consumer how dangerous even one trip to a tanning bed was. 20% chance of increasing your rate. And unfortunately, tanning beds in this country are regulated state by state, and some cities take over, some counties, but there's nothing uniform like there is in Australia. Australia used to have the largest rate of skin cancer, but because of a very aggressive plan that was subsidized by the government, tanning beds were outlawed. In fact, if you know the population of Australia, most of the people there are European, and it's below the equator, so skin cancer was prevalent. And now, if you go to school, if your child goes to school in Australia and doesn't have a hat, your child cannot go out and play. So that is a reason that the government got so involved in skin cancer prevention that helped decrease the rate. Right now, New Zealand, just recently in the past 2 months, took over #1. So I hope they can wage a similar battle. But some of the things that our foundation gets involved with, and we are predominantly prevention and education, are trying to reach people in the community about what they can do to help prevent skin cancer. And one of the new initiatives we're working on this year with the Melanoma Foundation of New England is a program for hairdressers and beauticians. And the thought is that most people will go and have their hair done a lot more often than they'll go and see a dermatologist. And we all know that there are things in our scalp that we might not see. So it's really important to educate the beautician, to educate the nail technician, to the spa person about telling their client how they best can be advised in terms of prevention. The program so far has had 6,000 clients, and it has saved lives. So there's several brochures outside on the counter. It's only a 60-minute program online. Legally, it's all vetted. No one has to worry about what they say. They're not going to get sued. What the beautician is instructed to do through the program is talk appropriately to their client and say, I see a lesion that I didn't see before. I think you ought to have it checked. So we're also involved. Last week we were filming Cure Connections, which is going to be an online program available for consumers, anyone that has melanoma, someone that is a caretaker, a relative. And what it does is it's a series of different interviews with doctors who talk about new therapies, with survivors, and even with people like us in terms of prevention. So as soon as that's up and running, I'll send Victoria an email and we'll get it up on our website. But I think that's very beneficial in terms of anyone who has melanoma, finding out about clinical trials, finding about new therapies, where to go. And then just the day-to-day things that we're always involved in. I'm sure you've seen our brochures. They're translated into French and Spanish, and it's a wallet size. Reminds people what to look for when they see a mold change. It goes over the ABCDEs in a very organized way, and it's a great thing to keep in your pocket because there's a small preparation on it, and that signifies if you have a mole or a lesion that is any bigger than this, you really ought to get it checked. And it is the diameter of a pencil eraser.
And we have the baby brochure too.
And we have the baby brochure, which Victoria was very influential, and a lot of parents would come to me and say, when can I put sunscreen on a baby? And when can I take my baby out? So that was the birth of the baby brochure. So hopefully they're available throughout pediatric departments and at pediatricians' offices. And I guess that's about it for now.
So nurses in the room, since hairdressers are now being educated, and probably barbers, I think we're going to include in that too, right? Especially for the men that are going bald and they should be wearing hats, but maybe they don't like a hat or whatever, and they're getting all that sun damage, and then it can lead to skin cancers and melanoma. If they're teaching their clients, really, why aren't nurses doing it? So we have to get this on the EMR, and I'm looking at Alice Nash right now because she and I have had several conversations about this, and she's going to help make this happen. And then we can get it onto all the EMRs. But with an educational endeavor like that, if nurses can do it, and through Molloy College we're going to have all of our nursing students now be skin cancer champions. We have 2,000 nursing students, and I was going to actually talk to Maggie on the way home about possibly getting a little button or something like, I can save your skin, ask me, something like that, save your skin, save your life, and then all of our nursing students will be in clinicals with a pin like that can then educate others as well. So we're making these little inroads, and we really appreciate your attention and assistance with this. Okay, next, Karen Hilton McGuire is going to speak.
Hi. The reason I'm here is because I have to give my thanks to Maggie and Molly's fund, because about 3 years ago, I started my doctoral studies, and Dr. Siegel is actually my
I was your advisor.
Advisor, yeah. And so she said, I'm doing this campaign here at Winthrop, please come. And I was sitting right over there with Peggy Murphy, and I was watching it. And I had gone the summer before to my cousin's house in Georgia, and she said, you have this little thing here. Did you look at that? Did you, seeing that there? And so, I kind of blew it off because I had moles all over me and whatever. And so then I came and I sat here and I said, uh-oh. I had the size of an eraser on my shoulder that it didn't have different edges. It was kind of round because it doesn't have to have, I'm looking at all these things, it doesn't have to have all of these asymmetry, border, color, diameter, and evolving. It doesn't have to do that, but it was getting bigger, so it was evolving. The diameter was a little round like that. The color actually was not black. It was kind of like a brown, but there was a little black inside. But there was like some white around too. The border was round, so it wasn't asymmetry. And so I said, because I was sitting here, I said, maybe I better get that looked at. Much to my surprise, I went to the dermatologist. He said, I don't know, it might not be anything. And by the end he said, let me just take a little biopsy. A week later, I had melanoma. And it was a very scary thing. So 3 days later, I had it all cut out. I had to get all the borders cut. All right, this little thing was no bigger than the end of my finger, like this. I had to go and they took the border around and cut it, and then they said they had to go and see if had it spread. So I went, they cut the board apart. I was waiting, and when you wait, it's pretty anxious. Yeah. And I knew that melanoma, malignant melanoma, and I had heard I could be dead, in a couple of. So anyways, obviously that didn't happen since I'm standing here. But then I went back and they took it's not like they just cut a little piece. They took a big chunk.
Shark bite is what it's called.
Chunk out of my back on here. I mean, if anybody wants to see the scar, they could see it. I have a scar this big from a little small lesion. So I did have to go and talk to an oncologist, and thank God she told me that I had a better chance of not doing anything than getting any chemo. So, and I have been good for 3 years now, and very much thank the public awareness campaign. So it really does make a difference what you're talking. You could save somebody's life. And I'm a nurse, so it really, you don't always know. So that's why I'm here, to tell my story and to give my testimony. And what you can do can really change somebody's life. So, and you guys have. So.
Thank you, Karen. Thank you. What's important to remember and to teach your patients and the public is that if melanoma is caught early, there's a 96 to 97% survival rate. So it's very, very important to catch it early. And we know that.
Can I just add one more thing?
Yes, of course you can.
I have to tell you, when I was growing up, I used to put like the baby oil on with
Yeah.
All right, but from my 35 and on, I use sun protective behaviors. I'm the person that went to Hawaii white and came back white, and I still got it. So it does, I'm going to segue into my friend here, Anna, who's my fellow PhD candidate in my cohort. And she's going to tell you why she's doing what she's doing in her research.
Right.
So,
yes, because what Karen's pointing out is even though as an adult she did very good sun protective behavior, and we can applaud her for that, but the sun damage has already been done when you were little, okay? 5 sunburns, even less than 5 sunburns, a person can get melanoma. Okay, it sets the stage for the DNA to change, all right? That's what the sun has done to the skin. So that's why it's so important, and that's why the baby brochure was very important. If we could teach moms and new parents to change the behavior from the start of the baby's life, which they've done in Australia, they're going to start to do in New Zealand, and I would like to have that more in Ireland too. I'm going to Ireland next week, and I'm bringing 16 nursing students, and we're teaching skin cancer in Ireland, because even though it's rainy like here now, they go to tanning beds, and their vacations, they want to get the sun because they don't get the sun. and they have very pale Irish skin, and they need to protect it, okay? And then Anna is going to talk about other kinds of skin as well, and another population. Go ahead.
Okay, hi, I'm Anna George. I'm a family nurse practitioner and a PhD student at Molloy College. Dr. Siegel is my chair of my dissertation, and I have done research residency during my program, and it was with Dr. Siegel that got me so interested to learn more about skin cancer.
Wrote the article with me.
And we
All
wrote
these
down
articles are out there, and
together.
Anna was co-author on this article.
And from all these people here, you see how important it is to really know about skin cancer and to practice it in your life. So I thought of taking it a step further. Why not we teach children? Children from the very beginning, if they learn how to protect their skin, and from that time on to look at their skin. So my dissertation is on middle school children's knowledge, perception, and behavior of acquiring skin cancer. And so we are going to be using, I'm doing a replication study, exactly what Dr. Siegel did, but I'm doing it in a school district, in Uniondale School, so it would teach the students, make them aware of looking at their skin closely from the very young age, showing them how to know the ABCDs and learn about their skin, protect their skin, look at all the preventions, and also about skin of color. As you see, my skin of color, and I always tell Dr. Siegel, I'm not going to get skin cancer. Look at my color. I have more melanin in me. So skin cancer is not as prevalent in my country or people of my color. But the fact is, not because it's probably less prevalent in the people of color, but the problem is, by the time you figure out that you have melanoma or skin cancer, it's late. So the mortality and morbidity on people of color is much higher. So they die because the time you found out that you have the skin cancer is way late. So this is why I think my study would really bring out how important it is that we can do something for them in the very early age. From when they go to school, we teach them how to protect their skin, how to detect it. Maybe we can make all the nurses school nurses aware on how to do a skin check along with when they see the students. So that is why I'm here to say that we should not only be starting later, but very early during the school years itself. And I hope my dissertation brings some significance and we take it from there.
That's right. Thank you, Anna.
Thank you.
And Anna's point is well taken about people of color. Bob Marley died of skin cancer, and he had acrolitiginous skin cancer, which is in the nail bed on his foot. And they initially thought it was a soccer bruise, okay? He went to the doctor, oh, don't worry, it's a soccer bruise. Turns out it was melanoma, and he died, okay? But the point is also with acrolitiginous, there are, at nail salons, they're doing the UV nails, okay? You put your fingers under this UV light. Please don't do that. Please advise others not to do that. And with the hairdressers and nail technicians and whatnot, we need to, nix that, because you can get that kind of skin cancer as well. Okay, so people of color is very important. Our study is going to include about 1,000 middle school children. The Molly Biggane Foundation has been teaching the middle school children in Garden City for years with the local dermatologist there. So that's been a great endeavor. And so we're going to keep on spreading the word. Okay, thank you, Anna.
In 1700s, Edward Tanner found that inoculation with smallpox virus offers protection against the smallpox, basically introducing the concept of vaccination. 200 years later, Dr. William Coley introduced Streptococcus virus in treatment of patients with bone sarcoma. And then in 1970s, Ralph Steinman suggested antigen presentation is absolutely necessary for T-cell activation. Not long ago, in 2011, the Nobel Prize was awarded for dendritic cell discovery. And as we all know, 2013 was a breakthrough of the year in science, in cancer therapy, cancer immunotherapy, which actually saved approximately 60 to 70% of lives of patients with skin melanoma. So the questions we have now is how much do we know about our immune system? how can we make our immune system to work better to fight cancer, and what can we do to improve our knowledge. So basic introduction to immunology, you know that immune system is subdivided into innate system and adaptive system. The innate system is very basic. It's responsible for recognizing self from non-self, and it consists of dendritic cells, natural killer cells, different proteins that can generate response against pathogens, granulocytes and monocytes. The innate system is priming adaptive immune responses, but it does not have any immunological memory. What we are trying to target here is adaptive immune system, which is B and T lymphocytes. And the way we are trying to target the T lymphocytes is to have them recognize the antigen and recognize cancer cell as an antigen. Different T lymphocytes in our body have different functions. They're produced by thymus, by bone marrow. Each T cell has unique antigen receptors, and our knowledge based on learning those antigen receptors and how we can alter them. You cannot fight cancer if you cannot see it. So how we can make T cells to become active to attack the cancer cells? So this is a very graphic picture of a T cell, if you will. Each T cell has multiple receptors. Some of them are activating receptors. Some of them are inhibitory receptors. So the ways to keep the T cells active is either to turn up the activation or to block the inhibition. What do we know so far? There are multiple trials, multiple studies around the country looking into different ways to keep T cells active. Probably one of the oldest therapies is cytokine therapy. The interleukin was FDA approved in 1997. Interleukin IL-2 promotes CD8 T cell and natural killer cell cytotoxic activity. People treated with interleukin IL-2 have durable response 6 to 10%, and what we know that out of those 6 to 10% people who actually did respond, very few of them recur after 2.5 years. So basically we consider people who are responders, they are cured. The problem with IL-2 is multiple significant toxicities, multi-organ toxicities. So it hasn't been used as much because the toxicity profile is sometimes hard to manage. The interferons were approved for adjuvant therapy. People treated with interferon was found to have progression-free survival for up to 1.7 years. Interferons promotes IL-2 activity. And we're also looking into hemopoietic factors such as GM, GCSF, and GCSF, which can potentially boost the inflammatory response and keep the T cells activated. There are multiple trials looking into manipulating T cells. Trials available currently in NCI, adaptive T cell therapy, the manipulation of T cells to make them more responsive to see the specific antigens, and TIL trials, tumor infiltrating lymphocytes, also aimed at making T cells recognize tumor antigens. We recently opened CAR T cell trial at Memorial, phase 1 trial, which uses genetically modified autologous T cells. I can tell you from my experience, most of the people are treated in ICU settings because of potential toxicity profiles, but we do have positive responses. We also didn't put it down here. We also have another trial with GP100 engineered protein looking into specific phenotype in the blood, HLA positive blood type. And it binds GPC100 protein into HLA cells and keeps the T cells activating. So we did have positive responses with that as well, particularly in patients with uveal melanomas, which is rare. And CD3 detected therapies, which are pretty much vaccinations, oncolytic viruses. So we know that BCG vaccine has been used in treatment of bladder cancer for a while, and now the TVAC was FDA approved last year for treatment of cutaneous melanomas. It's a genetically modified oncolytic herpes virus, and the systemic response rate was approximately 40%, which is high. The problem with TVAC, you need to have easily injectable cutaneous lesions in order to be able to use it. If you don't have cutaneous lesions that are easily accessible, you would not be able to use the vaccine. What I'm gonna talk more about is checkpoint inhibitors. The cytotoxic T lymphocytes associated protein, which is CTLA-4, known as ipilimumab. Programmed cell death protein 1, which is PD-1 drugs, known as Keytruda or pembrolizumab, and nivolumab or Optiva. Programmed cell death ligand protein, and combination therapies of CTLA inhibition and PD-1 inhibition. So the elder drug out of those group is ipilimumab, which was FDA approved in March of 2011. It was tested in 2 different doses. It was tested in 3 milligrams per kilogram versus 10 milligrams per kilogram. We used 3 milligrams per kilogram for treatment of melanoma. The 10 milligrams per kilogram was approved for adjuvant settings. The response rate reported with ipilimumab monotherapy was approximately 10.9%. Some studies cited 10 to 15%. What's important to remember with ipilimumab that sometimes it can make things look worse radiographically before they start looking better. We've seen delayed responses to ipilimumab quite frequently, so our advice would be to get the confirmatory scan when you suspect progression after initial treatment with ipilimumab. You need to get confirmatory scans because a lot of times you see the inflammatory response, the lesions seem to be more inflamed, and then after a certain amount of months or weeks, you will see a reduction in melanoma metastasis. Pembrolizumab is the first PD-1 drug approved by FDA in September of 2013. Pembrolizumab was produced by Merck company. The dose is 2 milligrams per kilogram given once every 3 weeks. Overall response rate in patients with cutaneous melanoma, that doesn't include uveal or mucosal or acral melanomas, just cutaneous, is approximately 40%. And what we're gonna come up, the data we're gonna present at ASCO this year is that medial response rate for the duration of medial response has not been yet reached. Nivolumab is BMS drug, and it was FDA approved a couple of months later in December of 2013. Nivolumab monotherapy, the dose is 3 milligrams per kilogram given every 2 weeks. When the drug is given in combination with CTLA-4 inhibitors, the dose is going to go down to 1 milligrams per kg. Overall response rate in patients with melanoma was cited 32 to 34%, and medial duration of the response also has not been yet reached. The combination of ipilimumab and nivolumab, this is a type, I apologize, was actually approved in October of 2015. Ipilimumab is given at 3 milligrams per kg with nivolumab 1 milligram per kg for 4 cycles, once every 3 weeks, followed by nivolumab monotherapy. Overall response rate was 61% in patients with cutaneous melanoma. PD-L1 expression played some role, but people who did not have PD-L1 still had excellent responses. And this profile was associated with a significant rate of toxicities, but from what we saw, people who weren't able to complete the entire course of 4 cycles still had excellent responses to combination therapy. The efficacy of nivolumab and pembrolizumab for different cancers, they approved also for solid tumors, for non-small cell lung cancer, renal cancer, ovarian cancer. A little bit lower, but still quite impressive. The safety summary For ipilimumab and nivolumab, the incidence of adverse events was much higher than with either of the PD-1 drugs alone, but out of those, only half of the adverse events were severe, grade 3 or 4 toxicities, which is still significantly different from PD-1s. If you compare 55% with ipi-nivo to 16 or 27% with nivolumab or ipilimumab alone, respectively. So I wanted to concentrate a little bit on recognition and management of those toxicities because I think it's really important, and I think our role as nurses here is really significant. For recognition of severity of adverse effect, I suggest using CTCAE. I don't know if everybody is familiar, but you can actually Google it. We use version 4 now. Version 5 is about to come up. It's very self-explanatory. If you want to look up the grade of the toxicity, you just, put whatever symptoms you're looking for, and they give you exact description of, what considered to be mild, moderate, or severe. So grade 1 for diarrhea would be less than 4 stools over the baseline. Grade 2 or moderate would be 4 to 6 stools over baseline. Grade 3 would be over 7, and grade 4 would be life-threatening. Another example is for pulmonary toxicities, pneumonitis. Also, if it's only radiographic interpretation and the person is asymptomatic, would be grade 1. If the person is symptomatic with some limitation to ADL but no severe hypoxia, grade 3. And severe symptoms, hypoxia, unable to perform LDL, require hospitalization, would be grade 3. If you look at the profile for ipilimumab or nivolumab or pembrolizumab, when I talk to my patients and I do some education sessions, it takes about 3 to 4 typed pages to go through every single side effect, which is named by the company. So pretty much to remember it, it can cause an inflammation anywhere you can imagine. It can cause inflammation in the brain, can cause encephalitis. It can cause inflammation in pituitary gland, hypophysitis. Can cause inflammation in thyroid, can cause inflammation in adrenal glands, can cause inflammation in the lung, can cause inflammation in liver, can cause inflammation in the heart, can cause inflammation in kidneys, can cause inflammation in colon, can cause inflammation in joints, can cause inflammation of peripheral nerves. So any itis you can think of can be related to immune therapy. Out of all those side effects, the most commonly seen are cutaneous side effects. Probably at least 50% of people would develop some sort of cutaneous side effects. Pruritus is the most common. It's seen with all PD-1s and combination therapy and ipilimumab monotherapy. Rash is usually macular papular, it could be pruritic rash, and a lot of times rash can vary from mild and not really bothersome to severe rash, and they actually added to toxicity profiles DRAS syndrome, which is cutaneous adverse event rash with systemic organ involvements, which can be life-threatening. So for management of those side effects, for pruritus, we usually suggest to use antihistamines, Sarna, Avena, anti-itch over-the-counter lotions. For management of rash, we use different potency topical steroids, depends on the grade of the rash. If something is really mild and you want to use hydrocortisone, it's fine. For moderate rash, which takes 10 to 30% of the territory, we would suggest triamcinolone. For severe rash, we can still use topical steroids, but higher potency. We can start with clobetasol cream, and if it doesn't improve in a couple of days, then we would suggest oral steroids at the doses of 0.5 to 1 milligram per kilogram a day.
Do you have a dose reduce or stop because of rash, because of certain other medications?
We dose delay. Usually we do not discontinue treatment unless the rash is really with systemic involvement. We had one patient who had grade 4 rash with anaphylactic kind of reaction, so we had to stop treatment. Other than that, we usually try to start with, I like to start with triamcinolone, but if it's more than a little bit on the chest, a little bit on the arm, I give a prescription for Clobex, and we use Clobex for 3 or 4 days. If there's no improvement with Clobex in that time, then we'll go straight to steroids. And you can try Medrol dose pack, which sometimes works, or you can do prednisone. And I usually give it for approximately a week or 10 days, and then if the rash is resolved to grade 1 or baseline, then you can resume the treatment and slowly taper the steroids. We resume the treatment when prednisone dose is down to 10 milligrams a day, so it depends on how long it takes you. But we rarely, unless it's really, really bad rash, we rarely discontinue treatment because of rash. And usually if they develop rash after the first or second treatment and you treat it appropriately, doesn't mean that they're going to continue having rash with subsequent therapies. They may not.
Yalena, can I ask a question?
Sure.
So how is it for your typical patient going through this treatment? It sounds like it's very rough for them. It sounds like they get quite sick. Is that correct? Or
Well, it depends on the therapy. If you're talking about combination therapy, I can tell you we had phase 3 study, which was expanded access ipilimumab-nivolumab trial. And we enrolled approximately close to 70 people, 68 if I'm not mistaken. It was supposed to be 4 cycles of combo followed by nivo monotherapy. I can tell you that maybe 25% of all people that were enrolled completed 4 cycles. Maybe 50% completed 3 cycles. So we really had people discontinued after the first and second cycles because of toxicities. We had few patients with pneumonitis, significant pneumonitis after the first cycle, which is a bit of an unusual presentation, who had to discontinue. But even people who discontinued because of toxicities after first and second cycles, we had great responses. And then when they got discontinued because of toxicities to a combo, we gave immune system some time to come down, and then we reintroduced PD-1 alone, and most of the people tolerated just fine. So I'll get to that, but the education is the key.
right?
The education, you need to educate your patients, and you need to be able to recognize the symptoms, because a lot of times we have people who go to a local emergencies room and they've been treated for pneumonia without any consideration that could be pneumonitis. Or we have people saying, I just ate Chinese food, I had a little bit of diarrhea and nausea, and they just let it ride for a couple of days, but Chinese food has nothing to do with that. So you should be able to recognize the immune-mediated toxicities and treat them. As soon as you start treatment, most of the people respond to immunosuppressive therapies. And I'll go over a little bit more.
Yalena, are most of the effects cumulative over the life of the drug?
Probably most commonly the side effects occur after the second treatment. So sometime within 6 to 10 weeks into the treatment, particularly diarrhea is most commonly seen after the second treatment, but we had pneumonitis after the first infusion, few days after the first infusion. I had people presenting with grade 3 or 4 rash after the first infusion. We found out that people cannot tolerate certain medicines. They get exacerbated allergic reaction in a setting of immune therapy. So typically, I would say you would anticipate the side effects after the second cycle, and then you treat them, you delay the therapy, and it does not necessarily have to be cumulative. They may tolerate the third cycle if you treat it early enough, but some people had to discontinue.
So are you able to do genetic testing to see how they would respond to the meds, or is that, are you not?
We do genetic testing for different reasons. We do a panel which tests over 300 genes, but we're mostly looking into different kind of mutations in case they would fail the immune therapy. We use immune therapy as a front line. If people have BRAF mutation, or if people would have KIT mutation or NRAS mutation, we're trying to use targeted therapy, but our preference would still be give the immune therapy frontline. In terms of genetic testing for immune therapy, we do look into PD-L1 expression, but the difference between people who have PD-L1 and people who don't have PD-L1 is not significant. They still respond. Diarrhea is probably the most common side effect. Diarrhea is something that you guys need to recognize and treat really promptly, because people do get very easily dehydrated. They get very deconditioned with diarrhea very quickly. Diarrhea can range from mild, moderate to severe. Mild diarrhea is less than 4 bowel movements over the baseline, and could be frank diarrhea, could be just loose, watery bowel movements. You also look whether or not they have abdominal cramping, if they have any more systemic presentation concerning for colitis, if they have any blood or mucus in stool. When people develop diarrhea for grade 1, you can try anti-diarrheal meds. From my experience, they don't work. Imodium doesn't work. We tried Asacol. It's anti-inflammatory. It's used for Crohn's disease. Anecdotally, sometimes it works, not always. We tried budesonide at 9 milligrams a day. Seemed to work for very low-grade diarrhea. For moderate to severe diarrhea, you go straight to systemic steroids. We use methylprednisolone for moderate, 0.5 to 1 milligram per kg per day, or oral equivalent, depends on overall condition of the patient. We give the steroids until resolution of the symptoms, and then we taper them slowly over 1 month period. Sometimes if you try to rush the taper, they have recurrent symptoms in the setting of a taper, so we try to take it slow. With severe diarrhea or colitis, we usually up the steroids to 1 to 2 milligrams per kilogram a day, and we call in GI consult. We're considering endoscopy, because sometimes you have clinical picture of colitis and CT scan shows no colitis. It doesn't mean anything. They can still have colitis which CT doesn't pick up, so we are trying to get endoscopies, some mucosal biopsies to see what kind of inflammatory process is going on. Anecdotally, again, people who develop immune-mediated diarrhea do better if they kept off dairy products. Don't ask me why, but dairy products exacerbate the symptoms. And if we give steroids for a while, a month or over, and it's more than 20 milligrams of prednisone a day, and we consider prophylaxis of opportunistic infections. We usually put them on Bactrim for PCP prophylaxis, and we keep Bactrim going for approximately 2 to 3 weeks after they stop the steroids. For people who have grade 2 diarrhea, which resolves within a couple of weeks, we may re-challenge the therapy. We probably would consider switching to monotherapy instead of re-challenging with a combo. For people who had grade 3 colitis, the combo is usually discontinued. Depends on the situation with melanoma. We would consider PD-1 monotherapy, but we would give it a little time. We would make sure that symptoms are completely gone before we start another immune therapy. Pneumonitis is probably one of the most significant side effects. It could be life-threatening. Mild pneumonitis, when you only happen to pick it up on surveillance CT scan, but the person is completely asymptomatic. We may usually delay the therapy, but we do not discontinue. We usually re-image to make sure it doesn't get worse. Not necessarily that it resolves completely, because sometimes you don't see the resolution if you do it to CT scan too fast, but at least it doesn't get worse. Moderate pneumonitis, when people present with shortness of breath with exertion. Some people can have cough only and don't have any hypoxia, don't have any dyspnea at all. For moderate to severe pneumonitis, we would like to have pulmonary involved. We usually ask for bronchoscopy to see what kind of inflammatory process is going on. Again, maybe some biopsies. We start using higher doses of steroids, so it's going to be methylprednisolone, 1 milligram per kilogram a day, or oral equivalent. We'll do frequent imaging to make sure that they're not worsening radiographically, they're not collapsing the lungs, they're not obstructing the lung. With severe pneumonitis, when people presenting to clinic with hypoxia, with dyspnea. I actually gave intravenous steroids bolus in clinic before the ambulance gets there. You give supplemental oxygen, you hospitalize, and you give higher doses of steroids. You give 2 to 4 milligrams per kilogram IV. And as you give higher doses of steroids, you obviously prophylax from opportunistic infections. Sometimes steroids don't work. Sometimes we need to add second-line immunosuppressive agents for diarrhea, pneumonitis. Sometimes we use infliximab or Remicade. Sometimes we use Celsat if steroids alone are not enough. And with severe pneumonitis, we usually taper steroids over a longer period of time, over 6 weeks at least, and we still had recurrent symptoms in setting of steroid taper. With pneumonitis, if it's moderate, we may consider re-challenging again with immune therapy. With severe, we stop immune therapy. It's too dangerous. And pneumonitis was actually linked to nivolumab. So I think nivolumab is the biggest offender in the combo than ipilimumab alone when it comes to pneumonitis.
You're so knowledgeable about this topic, and I know that people have a lunch break, so I was wondering if you'd be able to, if you don't mind, just summarize for us to allow the audience to ask any questions that they may have.
Sure.
That'd be wonderful.
So
Thank
I
you
just
much.
wanted very quickly give you an overview. This is a CT scan evident of pneumonitis. You see all those white ground glass opacities. Liver enzymes are quite frequent, so again, the steroids is the key to go. Sometimes for severe LFTs, we would want to do Celsat as a second line in addition to steroids. Endocrine disorders, we suggest to check TSH with each cycle of therapy and then respective T3, T4 if TSH is abnormal. If people present with headaches or present with any visual symptoms, we suggest doing brain MRI to evaluate for hypophysitis or do the full endocrine panel to evaluate for adrenal insufficiency and hypothyroidism. And then, going backwards here. And then this is a CT presentation of hypophysitis. You see the pituitary gland is enlarged. We actually happen to have phone calls from radiologists saying, oh, your patient may have new pituitary metastasis. And when you review the scans, like, I don't think so. I think this is just all inflammation. So less common is flu-like symptoms, arthralgias, neurological adverse events, interstitial nephritis. Now, as I mentioned, the education here is the key. So my take on it, I do the educational session with patients before we start any treatment, and I spend a long time trying to educate them. The key here is they need to understand if they develop any symptoms at all, they need to be able to reach a provider 24/7. They need to be able to call, and they need to know when to go to the emergency room. Because if you don't treat it very early and you don't recognize the side effects early enough, then you may be in trouble later on. The nurses need to know about the side effects, because a lot of times we have people admitted in different hospitals and we get calls from emergency room saying, now, we have your guy with pneumonia. Like, can you send the images? Can you try to start steroids? Just to be on the safe side, just start steroids if we need to. And usually end up being immune-mediated toxicity. So follow-up is really important. I tend to call, if people are fragile, if people are not very reliable, and I have the sense that they may not call right away if something happens, what I do, I actually put them on my calendar and I call them few days after treatment just to make sure that they tolerate the therapy well, and if they have any questions, if something prompts them to give me more information in terms of how they tolerate the treatment. We do it with every cycle of therapy now. We do it with combination therapy as a must. We're looking for any changes in liver enzymes, most common. Not uprised bilirubin, but uprised AST/ALT mostly. Seldom we saw cases of interstitial nephritis, which was biopsy proven to be immune-mediated, but not very commonly. We do check TSH with each cycle as a must. We still get CBC drawn with each cycle. We had a couple of cases of significant myelosuppression with platelet count going down to 40s in absolutely healthy otherwise individuals. Very rare. but it happens, so we do check that. What we are working on, my project, which I just submitted to IRB and got approved now, is to see how often do you need to continue doing labs with each cycle. Like, you have to do it with combination therapies, that's a must, but with PD-1s alone, when people are out of the acute phase, when they completed, let's say, first 3 months of treatment and they're just getting therapy and they're tolerating fine, do you really need to do that? We don't think so. We still do it because it's a hospital policy, but my goal is to prove we don't need to do that so frequently. We had so many, we probably had over 20 clinical trials between 2013 and 2015 before the drugs got approved. We consented 5-7 people a day to different trials who couldn't get access to immune therapy otherwise. Lucky now, with FDA approval, the numbers of clinical trials a little bit lower of enrollment, but we are looking into different approaches. We have this trial which is going to open up. We had a piece of the trial, and now we're going to open up another part of this trial, which is looking into GP100 engineered protein, which I mentioned before. It's another way of targeting the T cells. What we're trying to see if people who get treated with this drug and respond to it, what's the percentage of different kinds of melanoma who may respond. We did have positive responses in uveal melanoma with this particular trial, and uveal melanoma is really hard to treat. We're looking to see if that particular drug can synthesize T cells and make people who progressed on PD-1 or CTLA-4 blockage to be more responsive to immune therapy. Anecdotally, from unpublished data yet, we know that there are some responses if you use the IC GP100 on people who are refractory to immune therapy and then reintroduce immune therapies, they become more responsive. So we're looking into that approach. We do get CAR cell trial. It's not done by our department, it's done by ICU physicians. People get admitted to ICU, they get infusion. The concern with that trial is cytokine release reaction. People can become hypertensive, can become tachycardic, can have some respiratory compromise. So the drug is given in the monitored setting, and they've been admitted for at least 3 or 4 days before they can be safely discharged. Those are the main 2 approaches we do at Sloan. We use TVAC. We are about to open another trial which is going to introduce another oncolytic virus to the lesion, so we're going to do that and see how that works, similar to TVAC. That's pretty much our approaches right now. Iris melanoma can be primary. You can also send pathology for a second opinion. You can always have independent pathology review without coming into a facility. You can send it to any of the major cancer institutions. You can send it to Sloan, you can send it to Johns Hopkins, to MD Anderson, and have them look at the pathology and see if they think it could be related. You can also compare genetics and primary pathology and the pathology from the secondary lesion.
So they can tell from that?
They can tell if they're related.
Primary.
Yeah. Or if it's a secondary skin cancer. We actually had quite a few incidents of secondary skin cancer with people treated with immune therapy and also people treated with targeted therapy. Keratocontomas, basal cells. People who get immune therapy for melanoma, the common misconception is that I get treated, I don't need to see a dermatologist because the drug is going to kill it all. It's wrong. It's very wrong. They need to be seen by a dermatologist for at least annual checkup, and a lot of times semi-annual, depends on the skin. Because a lot of times we see secondary cancers on the skin. But if you do genetic testing, you can tell whether or not it's related to the primary lesion.
But one of the things with ocular melanoma, melanoma of the eye, is that a lot of the young teens that like to go to tanning salons also don't like to wear the goggles to protect their eyes because they don't want to get a rim around their eyes, I guess. And they are getting ocular melanoma. So they're getting their nails done, they're getting their eyeballs zapped. Okay, so we need to do that teaching. And prevention is so much better than having to go through all these side effects and this treatment that sounds so scary and so toxic, right? That we can prevent that from happening. We can prevent the need for that if we do a good job with prevention. But Oliver Sacks is a well-known author. He died recently of ocular melanoma. So yeah, that's a thing. Scary.
Yeah, unfortunately, there is no good treatment for ocular melanoma nowadays. There are multiple trials. One with MEK inhibitor was quite promising on phase 1 trial. The phase 2 trial, I don't know if it's my personal opinion, maybe a combination they choose with chemotherapy, but the drug didn't show to be effective on the phase 2 trial as it was on phase 1 trial. So that approach was closed up, and they're trying to use this ICP 100, ICMGP 100, didn't say it right, for uveal melanomas now, and they do have some responses, but there's no good treatment. And I can tell you it's not a lot of trials available for uveal melanomas too. But we did have a patient with choroidal melanoma, uveal melanoma, who had very indolent disease, who actually developed some cutaneous metastasis in the orbit. So it could potentially be related, to answer your question, but you need to do the genetic testing to make sure. It could be unrelated too.